session, the first session will be surgical management of breast cancer. Dr. Terry Mamounas from USA, Deputy Chief Medical Officer for Surgical Service, Clinical Director of Breast Program, and he will speak about surgical management of axilla, past, present, and future. Thank you.
Okay. Thank you very much, and I'd like to thank the organizing committee for the invitation. It's a pleasure to be here to discuss surgical management of the axilla, and I actually have two talks sort of back to back. So the first one is, as you see here, you see the slides, it's surgical management of the axilla, past, present, and future. And then the second one will deal with surgical management of the axilla after neoadjuvant chemotherapy. So as we all know, the surgical management of the axilla for patients with operable breast cancer has undergone significant evolution during the past 30 years or so. And of course, you know that axillary lymph node dissection was established as the undisputed standard of care, not only for the last few years, but for over 120 years almost. Since Halsted radical mastectomy. And it remained so for many years until his therapeutic role was actually challenged by randomized clinical trials. And one of those trials, as you know, was the NSABP B04 trial that actually compared for patients with clinically non-negative breast cancer radical mastectomy, which is the standard of care, which included, of course, axillary dissection and block, to total mastectomy with or without radiotherapy. And in the one arm of total mastectomy, there was no formal treatment in the axilla. Of course, these patients were clinically non-negative, but when you looked at the radical mastectomy arm, about 40% of those patients had pathologically positive nodes. So despite of that, you would have expected the other arm to have similar rates of axillary nodal positivity. Despite of that, as you can see on the data in the last update in 2002, there was no difference in overall survival or even disease-free survival. So that essentially was one of the first demonstrations that elective axillary dissection did not improve outcomes for patients with breast cancer, despite of considerable proportion of patients having residual disease. However, even after the B04 trial, we still did axillary lymph node dissections, and there were multiple reasons for that, despite knowing that the survival would not be affected. Because obviously axillary dissection provides a very good local control in the axilla, also provides us information on staging and estimation of risk of recurrence, and can help us with the decision of adjuvant systemic therapy. Back in the days when we moved to the B04 data and started using adjuvant therapy, nodal positivity was what we went by to give adjuvant chemotherapy. But over time, and of course currently, the role of nodal status for determining systemic therapy can decrease, particularly when we started using genomic profiling and also with the use of neoadjuvant chemotherapy, and we'll talk a little bit about that later on. But then sentinel lymph node biopsy came around, at least it was established almost about 20 years now, where we did the randomized trials that showed us that you can get the information you need in terms of systemic therapy with considerable less morbidity. So over the last few years, there has been a roadmap to try to decrease the role of axillary lymph node dissection over the use of sentinel lymph node biopsy without affecting survival and other long-term outcomes. And as I will show you some of the data, we pretty much eliminated axillary lymph node dissection for patients with clinically negative axilla and negative sentinel lymph node biopsy. We've now significantly diminished the use of axillary lymph node dissection for patients with clinically negative axilla and a positive sentinel node, at least one or two positive sentinel nodes. And of course, we also have shown now that we can diminish the use of axillary lymph node dissection for patients that would then present with involved axilla and get with or without histologic confirmation, and then we use neoadjuvant chemotherapy to downstage the nodes and potentially save the axillary dissection for those patients. We'll discuss more about that in the next talk. So there have been several randomized trials comparing sentinel lymph node biopsy alone to sentinel lymph node biopsy followed by an axillary dissection. I'm showing you here the largest one. This is the NSABP B32 that accrued over 5,600 patients with clinically negative axilla. They were randomized to either sentinel lymph node biopsy alone or sentinel lymph node biopsy followed by an axillary dissection for group 1, and group 2 just sentinel lymph node biopsy alone. But if the sentinel lymph node was positive, then axillary dissection also happened in group 2 for patients that had positive nodes. And what we presented earlier was that the identification rate was pretty high, 97%. The false negative rate wasn't that low, but for a multi-center trial was about 9.8%. The average number of sentinel nodes was 2.9, and interestingly, the false negative rate actually depended on the number of sentinel lymph nodes removed, something we've seen time and again in several of the trials. So it was almost double if one sentinel node was removed, because there was only one, and then about average if two sentinel nodes were removed, as you see in the bottom of the slide, and then progressively less as more and more nodes were removed. This has some clinical implications, not so much in the upfront surgery setting, but in the post-neoadjuvant sentinel lymph node biopsy setting. We'll discuss that later on. Of course, the long-term outcomes that we've seen in many of the randomized trials were no different, whether you did the axillary dissection or not after a sentinel lymph node biopsy. This is disease-free and overall survival. And more encouragingly, the rate of axillary recurrence that we see here on the red on the bottom was very low, both in the axillary dissection group, 0.2%, and even in the sentinel lymph node alone group, sentinel lymph node biopsy alone group of 0.5%, very encouraging. And of course, what was different was that the morbidity from axillary surgery was significantly less with the sentinel lymph node biopsy than with the axillary dissection. We can see less shoulder abduction deficit, less arm volume difference in terms of lymphedema, arm numbness, and arm tingling. All these sequelae of axillary lymph node dissection were diminished with sentinel lymph node biopsy alone. Furthermore, the results of the B32 and several of the other trials with negative sentinel lymph node biopsy allowed us to proceed with examining the role of sentinel lymph node biopsy even when the one or two sentinel nodes were involved. And that was, of course, led to the ACOSOC Z11 trial that compared very similar design to the B32 and other trials, sentinel lymph node biopsy with or without axillary dissection for patients that have one or two positive sentinel nodes. And as you can see, this included patients with lumpectomy only with breast radiotherapy. And although the original sample size was about 2,000 patients, they ended up accruing about half of those, but eventually were able to report the results. And when they looked at how many patients had residual known sentinel nodes in the axillary dissection group, about 27%. So about a quarter of the patients or more had residual nodes left behind. Despite of that, as you can see, disease-free survival and overall survival was not different between the two groups. In fact, if anything, the sentinel lymph node biopsy lines are on top of the axillary dissection, which is kind of interesting. We don't see that in other trials. Nevertheless, they proved non-inferiority of the sentinel lymph node biopsy compared to the axillary lymph node dissection. Now, when they initially presented the results with 5 years, the axillary recurrence rates were very low. It was 0.5% at 5 years with the axillary lymph node dissection, and by 10 years was the same. And with the sentinel lymph node biopsy was about 0.9% at 5 years, and only one more case of axillary recurrence occurred by year 10 with a rate of 1.5%. So the original concerns that maybe it's a short follow-up, we have to wait till 10 years at least to see if there are more axillary recurrences, did not come to fruition. So very stable results from 5 to 10 years and very low rates of axillary recurrence. Now, one of the questions is this applicable with other trials in similar settings, and what about mastectomy patients? We didn't include any in the Z11. There have been several other trials that looked at the same question. The IBCSG 2301 took patients with micrometastasis in the sentinel nodes, more than or equal to 1 micrometastasis. Very similar design, randomization to axillary lymph node dissection or not. And in that trial, about 9% of the patients had mastectomy, and about 13% of the patients had positive non-sentinel nodes. So here, clearly lower burden of disease in the non-sentinel nodes. Similar follow-up now for 10 years. You can see the data on the right side. Absolutely no difference in disease-free and overall survival. And ipsilateral axillary failures were actually very low. In the no axillary dissection group, 2%, and with the axillary dissection group, less than 1%, but very low for both groups. And more recently, we heard of another trial at San Antonio in 2021, and eventually published. This is the SYNODAR 1 trial, again, very similar design to the ACOSOC Z11, but in this trial, clinical non-negativity was not assessed only by the finger of the surgeon, but also by axillary ultrasound. And I think that's an important development. We'll discuss a little bit more about that later on. Assessing the axilla with ultrasound allows you to detect some disease in patients that potentially would have clinically negative axilla by palpation and minimize the disease in the axilla. So same design, sentinel lymph node biopsy alone on the right versus axillary lymph node dissection on the left. About 400 some patients in each group, similar to the ACOSOC Z11. About 20 to 23% of the patients in the trial had mastectomy, and the axillary burden, actually the non-sentinel burden positivity was higher, was 44%. So there were patients with mostly macrometastasis and a little bit more disease, despite the axillary ultrasound. The data were presented with short follow-up, almost a couple of years of follow-up. There was no significant difference in relapse-free or overall survival. And as you can see, axillary recurrence was also very low, 0.22%. But of course, we have to wait for longer follow-up from this trial to see if the numbers will change. And another trial worth mentioning is the AMAROS trial conducted by the Dutch group. And this was a trial that took a little bit different approach for patients with clinically negative axilla and a sentinel lymph node biopsy that reveals positive sentinel lymph nodes. Patients were then randomized to either completion axillary dissection or targeted axillary radiotherapy to see if radiotherapy was good enough to control the disease in the axilla. In that trial, patients with clinical T1 and T2 and 0, about 17 to 18% of the patients had mastectomy, and the non-sentinel node positivity was about 33%, so intermediate burden of disease. The primary objective, obviously, was to demonstrate non-inferiority between the radiotherapy to the axillary lymph node dissection. And again, the rates of axillary recurrence were very low, which initially led to an underpowered analysis for the trial. But eventually, if you see the 10-year data on the right, there was no difference in disease-free and overall survival. To the bottom right, we see that axillary recurrence was actually very low, with the axillary lymph node dissection 0.93% at 10 years, and axillary radiotherapy double that, but 1.82%. What was interesting also was that the rates of lymphedema were significantly less in patients that underwent axillary radiotherapy compared to those that underwent axillary lymph node dissection. And that actually put us in the predicament as surgeons to say, well, you know, we may have a way of giving the patient less lymphedema resulting in an equal outcome. So made us less enthusiastic about completing the axillary dissection for patients that have 1 to 3 positive nodes, but we have the alternative of radiotherapy. So over the years, of course, other factors have contributed to the de-escalation of axillary surgery. Obviously, the sentinel lymph node concept is paramount to that, but also adjuvant systemic therapy decisions, as I said before, are largely now predicated on biomarkers, ER/PR, HER2 status, and genomic classifiers, rather than nodal status, particularly for ER-positive, HER2-negative patients. Of course, randomized clinical trials, as I showed you, have shown now that the low burden of axillary disease can be safely treated with adjuvant systemic therapy and radiotherapy, because even in the ACOSOC trial, there was some spillover of radiotherapy into the axilla, avoiding the need of axillary lymph node dissection, even if there were 1 to 3 positive nodes. And of course, with a greater use and increasing effectiveness of neoadjuvant chemotherapy, this also has led to substantial downstaging of lymph node positivity. So what are some of the relative questions as we look into the future, what we're trying to achieve now? And I'll mention a couple things here. One is the movement to potentially, excuse me, even avoid send lymph node biopsy altogether in selected patients with clinically negative axilla. In fact, some studies in the past have shown that axial dissection for these patients doesn't improve outcomes. And the second is, how can we now minimize the adverse sequela of axial lymph node dissection if axial lymph node dissection has to be performed? So I'll touch on those in the last part of my talk. So can we avoid send lymph node biopsy in selected patients with clinically negative axilla? Well, again, as I mentioned, there has been no therapeutic advantage in performing axial lymph node dissection in clinical N0 and send lymph node biopsy positive patients, as we already discussed, if you undergo breast conservation and radiotherapy, but also if you undergo mastectomy. We have not as many patients for this category, but certainly increasing. And of course, the sensitivity of preoperative axillary ultrasound with core needle biopsy is about 80%. And importantly, a negative axillary ultrasound really excludes the presence of N2 and 3 disease. It doesn't exclude some smaller involvement in the nodes or the sentinel nodes, but it excludes pretty much N2 disease in 93 to 96% of the time. So you can be assured that the patient doesn't have a lot of lymph nodes if you decide to omit even the sentinel lymph node biopsy. Now, when is sentinel lymph node biopsy still necessary for local control? In other words, why would you need to do it versus not doing it at all? Well, if you start looking at different subtypes of breast cancer, for patients, for example, with triple negative or HER2-positive breast cancer, knowing the sentinel node is still needed sometimes for decision making. For example, to choose adjuvant therapy regimen if you're trying to de-escalate. If you have an older patient with a small T1 lesion and you want to give him adjuvant therapy, you're not sure sometimes if you need to go all in and give the more aggressive adjuvant therapy versus a more de-escalated regimen. For example, the APT regimen in HER2-positive patients. So knowing the sentinel node upfront and do surgery upfront allows you to either escalate the adjuvant therapy or not. On the other hand, most of these patients go through neoadjuvant chemotherapy. And of course, post-neoadjuvant chemotherapy, sentinel lymph node biopsy is needed to detect appropriate use of radiotherapy and potentially appropriate post-neoadjuvant chemotherapy, such as, for example, capecitabine for triple-negative breast cancer, T-DM1 for HER2-positive, or olaparib for patients that have BRCA1 mutations, because these are how we triage these patients to receive these therapies. And then for the ER-positive, HER2-negative patients, which is really where we'll be focusing in de-escalating sentinel lymph node biopsy, in most premenopausal patients with ER-positive, HER2-negative breast cancer, nodal status and genomic classifiers can detect actually what type of adjuvant therapy we use. We use adjuvant chemotherapy, we add ovarian factor suppression, and we use nodal regional radiotherapy. But in most postmenopausal patients with ER-positive, HER2-negative breast cancer, pretty much genomic classifiers can detect appropriate adjuvant systemic therapy. In fact, if an oncotype score is less than 25, there's no benefit from chemotherapy, whether you know negative or whether you know positive. And of course, nodal status and genomic classifiers can potentially dictate the use of CDK inhibitors, which is they're used in the high-risk patients, duration of endocrine therapy, and use of post-mastectomy or regional nodal radiotherapy. So there's some reasons why you want to know the nodes, but in sometimes you may not. And that's sort of why we're pushing now to potentially de-escalate sentinel lymph node biopsy. So in postmenopausal, let's limit now to the ER-positive HER2-negative patients postmenopausal, which is the group that potentially is the low-hanging fruit. Can sentinel lymph node biopsy omitted and is local control compromised? Well, going back to one of the trials that was conducted back in the 90s, the CLGB 9344, this took women 70 years of age with stage 1 breast cancer that had breast conserving surgery, randomized them to either tamoxifen alone or radiotherapy and tamoxifen. The idea was to de-escalate radiotherapy for these patients. And then for those patients, axillary dissection was optional. And in fact, it was allowed, but it wasn't encouraged, and about 62% of the women did not have any assessment of the axilla. There was no axillary dissection. And despite of that, although the local recurrence rate was higher in the tamoxifen group, as we see here, 10% versus 2% in the radiation group, axillary recurrence was very low in both. It was 0% with radiation and 3% with no radiation, despite the fact that 2/3 did not have any surgery in the axilla. So that was an observation that actually told us that maybe we don't need to be all that aggressive in the axilla for patients with T1 tumors that actually have very low chance for axillary positivity. And of course, in the United States, the SSO recommendation of the Choosing Wisely says probably don't need to do sentinel biopsy in women 70 years or older. Now, do we all abide by that? And a very good 72-year-old, we're not going to do a sentinel biopsy? That's not necessarily the case all the time, but we're also trying to find reasons why we need to do it. It's going to help us in making a therapeutic decision. And of course, for patients under the age of 70 still, it is the standard of care. Now again, what precipitates this need to actually de-escalate axillary surgery is the fact that in all the trials that we've looked at sentinel lymph node biopsy, even in sentinel negative patients or sentinel lymph node positive patients, the rates of axillary recurrence that we see on the left are very low. In B32.5%, I saw you all these numbers, I don't have to repeat them, 1.5% in the ACOSOC Z11, IBCAG 2%, Synodar 0.22%. And even in the AMAROS trial, as I mentioned to you earlier, 1.82%. So despite the fact that we leave residual disease in the axilla in a considerable proportion of patients that you see in the middle column, we do see very low rates of axillary recurrence. So there have been now several trials that have been designed and conducted, some of them finished already, in Europe mostly. The SOUND trial essentially takes patients with clinical T1 and 0 cancer undergoing breast conservation with a negative axillary ultrasound and randomizes them to sentinel lymph node biopsy plus or minus axillary dissection if the sentinel nodes are positive, and you need to do it, versus no axillary staging at all. And clearly, not doing sentinel lymph node biopsy does avoid some morbidity. Even that the morbidity of sentinel biopsy is less, clearly we do see some. So in a planned, for example, ancillary analysis from the study, there was a high rate of early postoperative disability in the sentinel lymph node biopsy arm, 24 versus 10.6%. So there is some morbidity even with the sentinel lymph node biopsy that we can avoid. The book 2013-08 Dutch trial, very similar design, T1 to T2 though, allowing even bigger patients to enter with breast conservation plus radiotherapy and randomization similarly to sentinel lymph node biopsy with or without axillary dissection if needed, or no axillary staging. And of course, the INSEMA trial is a very large trial, almost 6,000 patients. It was planned with clinically T1 and T2. Same randomization, no axillary staging versus sentinel lymph node biopsy, and I will discuss this, that if you have a sentinel biopsy, there's another randomization to axillary dissection versus not. And despite the fact that this trial allows clinical T2 patients to enter, the median age was 60 years, and 89% of the patients that were accrued in the trial was actually T1. So I think very judiciously the investigators put patients that had low risk for axillary involvement. 94% were grade 1 and 2, and 97% of the patients was ER/PR positive, and only 8.5% were HER2 positive. And interestingly, when they looked at the group that had sentinel lymph node biopsy, 83% of the patients were PN0, and 16% of the patients were PN1, and only 0.4% of the patients were PN2. In fact, 1.3% of the patients only had 3 or more macrometastases. So investigators are able to select patients that have very low risk of PN2 disease by axillary ultrasound and proper tumor size selection. Now, in San Antonio a couple of years ago, they also presented some patient-reported outcomes from the INSEMA trial, and it's worth looking at, again, these outcomes in terms of quality of life. And here I'm showing you again the schema of the trial to emphasize that besides the randomization 1:4 to no sentinel lymph node biopsy versus sentinel lymph node biopsy, if you have the sentinel lymph node biopsy, there was a second randomization to axillary dissection versus not, essentially like the Z11 trial. And when they reported the quality of life, we see here that there were significant differences in the breast symptoms, but most importantly in arm symptoms, even when you compare sentinel lymph node biopsy to no sentinel lymph node biopsy on the left side were the arm symptoms. And of course, furthermore, when you compare the axillary dissection arm to the sentinel lymph node biopsy, there was more difference in the arm symptoms, as you see on the right curve. So clearly, even just the sentinel lymph node biopsy induces some morbidity that we can avoid if we don't have to do it safely. So to finish, this is sort of what we're moving. Obviously, we have to wait for the results of these trials to avoid doing sentinel lymph node biopsy. At this point, it is the standard of care, at least for patients under the age of 70, and selectively maybe for patients over the age of 70. But hopefully, we may be further de-escalating sentinel lymph node biopsy. But if you do have to do an axillary dissection, how can we potentially decrease the morbidity? And I'll leave you with a couple concepts here without spending too much time, since time is running late. One is the concept of axillary reverse mapping, which essentially says that the anatomic drainage of the breast and in the arm are different. So there's some nodes that drain the arm and other nodes that drain sentinel lymph nodes or axillary nodes that drain the breast. And if you can identify the nodes that drain the arm, potentially you can preserve them either during a sentinel lymph node biopsy, but more importantly, during an axillary dissection. This is a concept that was initially published by Bonetti, but eventually it's been promoted by Suzanne Klimberg, who leads the trial in the United States. Now, there is some crossover between the nodes from the arm and the nodes from the breast, and particularly if there's heavy involvement of the axilla, some of the nodes from the arm will be involved, but with a low axillary involvement, most of the nodes from the breast are not involved. Most of the nodes from the arm are not involved with disease. And of course, but crossover happens about 0 to 10% of the times with the sentinel lymph node biopsy. And arm node lymphatic can be sacrificed up to about 18% of the times when you do axillary lymph node dissection. And the lymphedema, when you do arm in small studies, appears to be small, 0 to 5.4%. So Suzanne Klimberg in the US leads a trial, the Alliance A22 1702. There's too many numbers maybe there, but anyways, that is a prospective trial to study the rates of lymphedema and regional recurrence after sentinel lymph node biopsy with or without axillary lymph node dissection, with and without axillary reverse mapping. So you can enter the trial if you have a lumpectomy or a mastectomy and a axillary lymph node dissection. And also with a mastectomy, you can even enter the trial if you have a sentinel lymph node biopsy with or without axillary dissection. Randomization between performing the reverse mapping or not performing the reverse mapping. The lympha procedure that we'll discuss next, the lymphovenous bypass, is allowed in either arms. The lymphedema assessment is done in regular intervals, and essentially total limb volume measurement by circumferential arm measurement. And lymphedema is considered if you get 10% increase in volume. This trial has completed accrual. Of course, the lympha procedure will muddy the water a little bit, but we'll see the analysis when it becomes available. And to finish, the lympha or lymphatic microsurgical preventing healing approach is actually a popular approach that now has been adopted in the US and internationally. It was originally proposed by Boccardo in this paper here, which essentially dictates to identify the lymphatics that drain the arm by injecting dyes in the arm, similar to the axillary reverse mapping, but then anastomose the lymphatic, these lymphatic channels to small veins in the axilla to reestablish the lymphatic circulation. So you see here how this is done. The anastomosis is a microsurgical anastomosis under the microscope, and you can see that you put it in a vein that has a valve, so there's no backflow, and that reestablishes some of the circulation. It's a fairly simple procedure. Now, we don't have a lot of data, and I must say that this sort of has been adopted in practice, and we do it in our institution. We offer it to our patients, but the data are not to the same extent that we see in big randomized trials. But small studies have shown, despite the fact that most of these patients received radiotherapy, had axillary lymph node dissection, underwent lympha, overall, the rate of lymphedema is about 4.8%. Again, this is mostly single arm trials. There's a small randomized trial by Boccardo, but essentially it's encouraging, but we cannot be necessarily definitive that we have to do this procedure for everybody to prevent lymphedema. But because it's easy to some extent, and you can do it right after the axillary dissection, this is something that we discuss with our patients. So in summary, I think it's fair to say that substantial de-escalation in the extent of axillary surgery has occurred in the last 25 years. Sentinel lymph node biopsy has become the standard of care for staging the axilla in patients with clinically negative disease in the axilla and negative sentinel nodes, and also in selected patients with clinically negative axilla and 1 to 2, maybe 1 to 3 positive sentinel lymph nodes. And axillary radiotherapy results in similar local control of the disease in the axilla with positive sentinel nodes with less arm morbidity. In postmenopausal patients with ER-positive HER2-negative breast cancer, potentially avoiding sentinel lymph node